Everyone, my name is Rami Tadros, and I'm an associate professor of surgery and radiology within the Division of Vascular Surgery at the Mount Sinai Hospital in New York. And I'm here to talk about calcification, the roadblock to success, and how to overcome it. When treating peripheral arterial disease that is especially calcified, there are a lot of roadblocks that need to be considered. One is difficulty crossing, challenging reentry, resistance to intervention, recoil, vessel fracture, hemorrhage, early and late failures, as well as closure device failures at the end of the case. Intravascular calcification is a complex process, and essentially you have bone formation within the vessel wall, especially within the media and the intermedia of the vessel wall. Some tips for success are: one, knowing how to cross, using reentry devices when you need to reenter, and how to best treat these calcific lesions. In terms of crossing, the number one tip I can give is to build a system with a lot of support. Use a long sheath that will bring you almost to the lesion or to the lesion. So determine the length based on the length needed. So 45 centimeter, 65 centimeter, 90 centimeter, 110 centimeter sheaths. That way you can bring the sheath right up to the lesion being treated, and that will help provide additional support for crossing. You can build a system with sheaths and guides and catheters. You can use support catheters, you can use crossing catheters, you can use telescope techniques. For example, one good combination is the Navicross system, which is an 035 system, and you can couple that with the Navicross 018 system, and the 018 will actually fit through the 035 Navicross, which will help provide a rigid support system to tackle and cross difficult lesions. Other options include using crossing atherectomy systems, such as the crosser device, which can also help cross calcific lesions. You can't always cross through the lumen, and when that happens, you need to consider subintimal recanalization and subsequent reentry. Calcific disease makes reentry difficult, but not impossible, and occasionally reentry devices are needed. Occasionally femoral and pedal access is needed, so going from above and from below to be able to cross these very difficult lesions. One reentry system to consider using is the Pioneer Plus catheter, which is an IVUS guided reentry system, and this could help with reentry. And you can see here, you go subintimal, you cross the area of the lesion, you can identify the lumen again with IVUS, and that can direct your reentry. You can see here the subintimal plane and then the lumen to help direct reentry. Probably the more commonly used, at least in my practice, is the Outback reentry device, which is a 6 French system that allows reentry similar to the IVUS directed system. There's a needle that allows you to puncture through and reenter. So this is a 67-year-old patient with CLI who had a severe SFA occlusion. You can see a long segment CTO, calcific disease, multi-level. So once you go into a subintimal plane, you go beyond the lesion that you're trying to cross. You can double over a glide wire and then swap out for an 014 wire, either a Grand Slam or a Whisper, your crossing 014 wire of choice. Usually it needs to be 300 length or more. You then track the Outback system through a 6 French sheath down beyond the lesion, and there's an L shape. You point the L towards the lumen. You can confirm that in several different projections, and then fire the needle forward, and that will hopefully allow you to enter the true lumen again beyond the calcific lesion. Once the needle is in the lumen, you can then advance your 014 wire. Once the 014 wire is in position, you often need to pre-dilate with an 014 balloon of some kind. I typically will use a 3 or 4 millimeter nanocross to dilate the site of reentry. So again, some additional views here. You can see the L is pointing towards the lumen. That's good. If the L is not pointing towards the lumen, you need to readjust. And again, you can adjust the gantry angle to be able to re-enter. And so here you can see that the wire, the 014 wire, being passed into the true lumen. You can see the calcifications there. And again, we'll dilate this with a 014 balloon, probably a 4 or 3 millimeter balloon. So once you're across the lesion, whether you're through the main vessel or subintimal, then you need to consider treatment options. You have angioplasty, you have a newer technology, lithotripsy, which I think is critical when it comes to treating calcific disease. You have different atherectomy systems. In my practice, I will typically use CSI or HawkOne, and then stenting, typically drug-eluting stents, either the Alluvia or the Silver in my practice. And then I have Viabonds for bailout purposes, especially when I'm worried about vessel perforation. Calcification definitely creates many challenges when it comes to treating PAD. It actually results in worse patency and multiple other issues. With regard to angioplasty, in my opinion, angioplasty alone as a standalone treatment is typically not enough. However, if you are going to attempt angioplasty alone, typically either a high pressure balloon such as a Dorado will be helpful. You can use scoring balloons or cutting balloons, and sometimes this could be done in advance of stenting to help improve vessel compliance. And then, of course, DCB, and some of these treatments can be coupled with each other. That said, in my experience, typically angioplasty alone for these calcific lesions is not enough. I think that these lesions are often very resistant to treatment. The shockwave intravascular lithotripsy system is a lithotripsy device similar to that used for extracorporeal lithotripsy, which we use for kidney stones, etc. This device creates ultrasonic wave, which can actually fracture the calcium and improve vessel compliance. And that can greatly improve vessel expansion and luminal gain. In terms of atherectomy systems, there are many available. Again, as I mentioned, the HawkOne directional atherectomy system is one that I use commonly in my practice. And I also use the Diamondback from CSI quite frequently. Not all atherectomy systems are good for treating calcium. The HawkOne is one of the devices that is very good at treating calcific disease, and the other are orbital atherectomy, mainly CSI, and the Phoenix device, which is a rotational system. The HawkOne is a directional atherectomy system that has a cutting edge that allows you to remove plaque. This is how this procedure is done. Using fluoroscopy, you bring the cutting edge to the level of the lesion, you activate the device, you activate the cutter, and then you advance the device slowly. And typically, you will adjust this device so that you can cut in usually 3 different directions. You can do 4, but typically 3 is what I do. And then, of course, there's CSI, which is a form of orbital atherectomy. You have this device that spins at a very high frequency, which can actually shave the calcium down, and that can often help improve vessel compliance. And again, it rotates at a very high frequency, allowing fracture of the calcium. Once the vessel's been prepped with atherectomy, you can then, again, attempt something like a drug-coated balloon. And if that's not effective, you can consider drug-eluting stents, such as the Illuvia or the Zilver PTX, and then subsequently angioplasty. Again, in calcific disease, you may need to resort to a high-pressure balloon to treat the lesion to ensure optimal luminal gain. And it's important to keep in mind, when treating calcific disease, there's always the possibility of vessel fracture, which may result in hemorrhage or pseudoaneurysm formation. Have Viabond stents available in the event that that happens. Typically, you can try a prolonged balloon inflation to see if there's resolution, but often that's inadequate, in which case using such a Viabond stent, covered stent, to treat that is useful. And then at the conclusion of the procedure, remove your sheath. Most closure devices are not extremely effective in calcific disease, and therefore be prepared to hold manual pressure for a prolonged period of time to obtain hemostasis. Thank you very much.